All right, let's start first by talking about axial spondylitis. And this is a brief outline that we're going to follow. And well, just to mention two quick things. In our case, the topics aren't in a specific section. Instead, we'll be discussing them as the presentation progresses. And at the end, if we have time, there will be a short round of questions on Kahoot, which is a website, just in case you want to start opening it and getting it ready. It's kahoot.es. All right, let's begin with a brief introduction. An ankylosing spondylitis or radiographic axial spondylarthritis is a spondylarthropathy, which falls under the category of spondyloarthropathy. And within this group, as we can see in the diagram, there are two main subdivisions, so to speak. Axial spondylarthritis, which predominantly presents with inflammatory type lower back pain, and peripheral spondylarthritis, where the most notable manifestations would be enthesitis or arthritis. Radiographic sacroiliitis is the hallmark of ankylosing spondylitis. And this is because chronic inflammation leads to ankylosis of the sacroiliac joint. Some studies show that a certain percentage of patients, around 10-15%, will never develop radiographic sacroiliitis, but it will only be detected through more sensitive methods such as magnetic resonance imaging. Regarding epidemiology, just a few data points. The global prevalence of spondyloarthritis is around 0.52%. It depends on the case series. This is due to the variability among ethnic groups and the prevalence of HLA-B27 within these groups. For example, axial spondyloarthritis is less common in South Asia. Radiographic forms are more common in men, with 2 to 3 cases for every case in women, and there is no difference in non-radiographic forms between sexes. The highest incidence occurs in the second or third decade of life. Regarding pathogenesis, it is still somewhat unknown, but it is known that the fundamental lesion is enthesitis. This enthesitis and chronic inflammation lead to erosion of the sacroiliac cartilage and hyaline cartilage, such as the bone, including the bone, as well as the bone. Subsequently, ossification occurs, and in more advanced stages, ankylosis will develop. There are several genetic components, such as IL-23 and IL-17, and a significant involvement of Th17 lymphocytes. These lymphocytes normally play a role in defense against bacteria and fungi. They carry out their function through IL-17, IL-17F, and IL-22, and they differentiate through molecules such as IL-1V, IL-6, TGF-V, and IL-23, which is considered the most important signal. However, it has also been observed that there is a subpopulation of Th17 lymphocytes that reside in the enthesitis of the axial skeleton, which differentiate and are capable of producing IL-17 independently of IL-23. Also important, as we have mentioned, is the association with HLA-B27. And this is thought to be related to 3 hypotheses currently under consideration. The first hypothesis is the arthritogenic peptide hypothesis. This responds to an assignment. It is due to an abnormal response triggered by the presentation of certain antigens, which may be either self-derived or external, such as bacterial antigens, where their presentation through HLA-B27 is not carried out properly, triggering an excessive immune response that primarily affects the joints. Although to date, clear evidence of molecular mimicry has not been demonstrated. Another hypothesis is the abnormal folding caused by HLA-B27, as it folds slowly and often incorrectly in the endoplasmic reticulum. This leads to accumulation in the cell's endoplasmic reticulum and activation of the UPR genes, resulting in apoptosis, inflammation, and the production of inflammatory cytokines. And the third hypothesis that is gaining traction is the ease with which this HLA forms homodimers of heavy chains. These accumulate on the cell surface and can act as antigen-presenting molecules that function as ligands. This would also trigger an excessive immune response. Apart from HLA-B27, some new lines of research are currently emerging that show that there is another set of genes. For example, LRAP1, which is a protein that functions by trimming peptides before they are presented to HLA-B27. And when its function is lost, this HLA would once again accumulate inside the cell and lead to apoptosis and inflammation. The IL-23, the IL-23 receptor uses STAT3 and TYK2 as its second ligand and secondary signaling pathway. There are also ongoing research lines on this, exploring the potential of CIS and variables associated with modifications. Regarding clinical presentation, there are two types: skeletal manifestations and extraskeletal manifestations. The main manifestation would be inflammatory type low back pain, which is the most common symptom. Another skeletal manifestation can be mistaken for atypical chest pain due to involvement of the costochondral joints. And this pain is sometimes confused with pleuritic pain because it worsens with breathing and with coughing. The pain even increases with palpation. There is also asymmetric peripheral oligoarthritis in some cases, and this is more common in the juvenile forms. This oligoarthritis predominantly affects the lower limbs. And hip arthritis would be the most severe and at the same time the most common form of arthritis. We also find enthesitis, which can manifest in the heel, the Achilles tendon, the patellar tendon, or the epicondyle, and it often represents the initial symptom or the most prominent early symptom. Regarding extraskeletal manifestations, the most common is acute anterior uveitis, especially in patients who are HLA-B27 positive, and there is no clear relationship between joint and ocular activity. There are less common cardiac involvements, such as aortic insufficiency, secondary to inflammation of the ascending aorta, heart blocks, and pericarditis. And in the spondyloarthritis population, acute myocardial infarction is more prevalent than in the general population. There can also be pulmonary involvement, although it is much less common than in other diseases. There are reported cases of slowly progressive fibrosis, predominantly affecting the upper lobes, and a restrictive pattern may appear in pulmonary function tests, mainly due to involvement of the thoracic cage. There are also neurological manifestations, which may include an atlantoaxial subluxation, similar to spontaneous psoriasis, as seen in rheumatoid arthritis, which can sometimes present with symptoms of spinal cord involvement. Cauda equina syndrome is rare, but very serious. And in patients with chronic inflammation and a long clinical course, arachnoiditis and arachnoid adhesions may occur. There is renal involvement, secondary to amyloidosis. We should also remember that kidney damage can result from prolonged use of NSAIDs. Additionally, in these patients, the prevalence of osteoporotic fractures is increased, and a decrease in bone mass can be observed from the early stages of the disease. There is also sometimes difficulty in diagnosis, as the pain from a vertebral fracture can be mistaken for symptoms possibly consistent with axial arthritis. There is also difficulty in assessment, because the presence of syndesmophytes can sometimes alter bone mineral density results in tests. Around 40–60% may present with inflammatory bowel disease, which is mainly detected through biopsy in the form of microscopic colitis. Symptomatic cases where the disease fully develops with clinical signs such as diarrhea and pathological findings are reduced to about 5–10%. We can also find psoriasis predominantly affecting the nails in around 5–10% of patients. Finally, we move on to the classification criteria, and ankylosing spondylitis was previously classified using the modified New York criteria, which are described here, and these primarily emphasize the value of radiographic sacroiliitis. This delayed diagnosis by around 8 years, and with the emergence of more sensitive tests, such as MRI and the identification of HLA-B27, the need arose to create new criteria, which became the ASAS criteria. Let's recall that both the criteria, modified New York, like the ASAS criteria, they are still classification criteria developed for research purposes and to group certain patients for study, but they can help guide diagnosis. The beginning of the ASAS criteria. ASAS would start with a patient experiencing chronic inflammatory type of pain lasting more than 3 months, and the onset would be before the age of 45. And there are two branches, the sacroiliitis or imaging branch, where sacroiliitis can be demonstrated either by X-ray or by MRI, and at the same time it should meet one of the spondyloarthritis criteria. Or the clinical domain, in which we find positivity for HLA-B27, and in this case, the patient should meet 2 clinical criteria for spondyloarthritis: sensitivity and specificity. Respectively, they are 82% and 84%. But if we consider the domains independently, this sensitivity and specificity can decrease in the imaging domain, down to 66 and 93% respectively. And if we consider the clinical domain, sensitivity and specificity decrease even further. Sensitivity around 53 or 54% and specificity around 82%. The criteria for spondyloarthritis that must be met are 1 in the case of the imaging domain and 2 in the case of the clinical domain. In the case of the clinical domain, these would include inflammatory back pain, a family history of spondyloarthritis, anterior uveitis, psoriasis, elevated CRP, peripheral arthritis, heel pain, enthesitis, or a good response to NSAIDs. And once classified as axial spondyloarthritis, we differentiate between radiographic or classic ankylosing spondylitis and non-radiographic axial spondyloarthritis.